Professor David Earn is a professor of mathematics, and Faculty of Science Research Chair in Mathematical Epidemiology at McMaster University. I didn't know that about you. His primary research interests are in infectious disease dynamics from the time of the Black Death to the present. He's a recipient of a CIHR New Investigator Award, an Ontario Premier's Research Excellence Award, and the Canadian Applied and Industrial Mathematics Society Research Award. And he's also a fellow of the Canadian Academy of Health Sciences. He's a member of the executive committee of the Michael de Groot Institute for Infectious Disease Research at McMaster, and co-leads the Canadian Network for Modeling Infectious Diseases, CanMod, which has been a fantastic national resource. So without further ado, I will turn the microphone over to Professor Earn.
Thanks very much, David. And thanks so much for inviting me here. It's really a pleasure to be at this lovely meeting, and to the Institute for Pandemics, and to have the opportunity to tell you about some things that I have been very passionate about for many years, which is not the COVID pandemic, and predates the COVID pandemic by a long way, but about previous pandemics, going back a long way, in some cases hundreds of years, and trying to learn from the data that we can find, which are nothing like the quality of data that we have for COVID, but from which we can learn many interesting and valuable things about epidemics and pandemics of the past. And I hope that after a few minutes, I will have convinced you that this is really an exciting and interesting thing to pursue. As David said, I am a mathematician, and I spend most of my time doing mathematical modeling. I'm going to emphasize the data in this presentation, and I will comment on the ways that what we've learned by modeling, but I'm not going to present a lot of equations and get deep into the mathematics. But I will be delighted to discuss the mathematical details with people who are interested afterwards. So I want to begin with a disease that is probably in most people's minds, at least before COVID, was in most people's minds if they thought about horrific pandemics that occurred in the past, and that's plague. So plague, unlike COVID, is a disease that's caused by a bacterium, and I'm not going to get into the microbiology, but I am interested in how it's transmitted. So again, unlike COVID or other viral diseases or many bacterial diseases, the way that plague comes about is that it's normally present in populations of rodents, and every so often there are large outbreaks in the rodents. And so we think of often as rats being the rodents that are most important, but they aren't necessarily the only rodents that are important. And the disease is transmitted by a vector, typically fleas, and those fleas can bite humans. And so when there's a big outbreak in the rodents, we can see the echo of that in a horrific epidemic in humans. Of course, if the pathogen enters the lungs, it can change character and become a directly transmissible disease, which we call pneumonic plague. So in that case, it doesn't need the vector, and so it's complicated. It starts as something that we think of as being present in rodents. It can become a major disease in humans, and then spread human to human potentially. Okay, well, I always can't help pointing out a remarkable feat of evolution of how this pathogen actually works. So this is a photograph of a flea whose belly is plugged up with the bacteria. And what happens is that when a flea feeds at a seriously infected host, it gets plugged up, its stomach gets plugged up with the bacteria, and it starts to starve, and that means that whenever it swallows, so when it tries to feed on somebody or another rodent, it regurgitates the bacteria into that rodent, and that's how the cycle continues, which always strikes me as incredible. But again, that is not going to be my emphasis here. I want to think about the transmission dynamics in the population. So before doing that, I want to remind you, if you don't know already, just how serious and horrible this disease can be. So plague begins typically with flu-like symptoms, malaise, fever, chills, and then it can take one of three forms. So if it gets into the lymphatic system, then you get these buboes, which can be, giant inflamed lymph nodes the size of grapefruits in principle. If it gets into the lungs, as I said, you get pneumonic plague, which is you're coughing blood. It's a very miserable situation. Alternatively, if it gets into the bloodstream, then you get characteristics that make it what is called the Black Death. So your fingers and toes, the extremities turn black, and that is why it was called the Black Death when people died after having these symptoms. Okay, well, if you get those horrible symptoms, how likely is it that you die? Well, I mean, COVID was bad. Other things that we're familiar with are bad, but the CDC estimates that if you get bubonic plague, then in the absence of being treated with antibiotics, about 2/3 of people die. That's pretty bad. And even in the presence of antibiotics, the CDC claims that in the US, over the decades or whatever they've been monitoring it, still 11% of people die. Of course, that's obviously going to depend on when you get the antibiotics. With pneumonic plague, if you really get full-blown pneumonic plague, almost everybody perishes after that. Again, of course, if you're treated with antibiotics early enough, that might not be the case. So this is an absolutely devastating and scary disease in a way that we're completely unfamiliar with, even after our experience of the last few years. Okay, well, how can we understand what happened in the past other than from descriptions like I've just given you? Are there data that can help us understand the patterns of plague epidemics in the past, and what can we learn from that? So let's look back in history. There were 3 pandemics of plague that occurred, that we're aware of. The first is known as the Plague of Justinian. That carried on after an initial introduction in the 6th century. It continued for maybe a couple of hundred years and killed maybe 25 million people. Take these numbers with a very large grain of salt, but these are estimates that people have made. Then the second pandemic began in the 14th century, and that continued for several centuries as well, and that's thought to have killed maybe half or 60% of the population of Europe. Then modern plague began in the 19th century, and people estimate, well, maybe 2 to 10 million deaths. It's interesting that the numbers that you can find have a wider error bar for the more recent times than older times. But the bacterium itself wasn't actually isolated until the late 19th century. So you might well wonder how it is that we even know that we're talking about plague epidemics in the past. And that was really a quandary and led to all sorts of debate over a very long period until fairly recently. And what turned that story is work that was led by a close colleague of mine, a colleague of David's as well, Hendrik Poinar, who is an evolutionary geneticist who works on ancient DNA and who we affectionately call Indiana Bones. And he led the effort to actually sequence the genome of the pathogen that caused people to die in 1348 in London, and that turned out to be a match to Yersinia pestis. So in fact, we do know that pandemic in 1348 was caused by the same pathogen that causes bubonic and pneumonic plague now. So that's the second pandemic. What about the first pandemic earlier? I mean, how do we really know that that was plague? But in fact, Hendrik and his group have been able to sequence DNA from surviving, actually from dental pulp extracted from skulls that survived from that pandemic. So in fact, yes, that was also Yersinia pestis. And then, of course, in the modern plague, well, that's what we're comparing against. There's no question there that it's Yersinia pestis. Okay, so we really do know that these are all Yersinia pestis. That's important data to get us started trying to understand the patterns of these epidemics. What kinds of data can teach us about what those epidemics actually look like in populations? Not was it plague or not, okay, we know that now, but can we actually learn something from the patterns of deaths in particular over time? And there are a variety of sources from the second pandemic that we can use to describe those patterns. So remember, the second pandemic began in the 14th century, so we think of the Black Death starting in 1348, well, a bit earlier, but in the UK in 1348, and going on until the Great Plague of London in 1665, and a bit beyond that. It actually finished in London shortly after that. 1665 is, in fact, a very interesting year, not just because of the plague. And that's because at the time, and I have to mention this because I'm a mathematician, Isaac Newton was at that time, one of the most famous mathematicians in history, was at that time a research fellow in Cambridge. And the university was closed because of the Great Plague of London, and so he had to leave. And wow, this is somebody who knew how to make the most of lockdown, let me tell you. So while Newton was holed up in his country house, he developed calculus, optics, and his universal law of gravitation. And that's kind of impressive, and I think, wow, what did I lock down? I'm sure that if I had not spent most of my time developing forecasts to try and help public health, that I'd have, solved many of the remaining mysteries of the universe. Well, maybe not. In any case, Newton is very inspiring, and if we think about the quality of the science that he did in mathematics and physics, well, can we be inspired by that to think about how we should go about finding data that might help us describe the plague? Well, if we want data that help us describe plagues, the Great Plague of London and others, then we obviously need written records that have survived until today. And they need to have been kept fairly systematically over the course of an epidemic. We're not going to be able to characterize the pattern of an epidemic if we just have some rough estimate of the total number of people who died during an epidemic. So we need details. Ideally, we'd have a death certificate for every individual who died and their cause of death, and we'd have full pathogen genomes associated with each individual. It's the kind of thing like we aim for now. Sadly, I don't think that's ever going to be a possibility. What can we obtain in practice in order to understand these ancient epidemics? And to do that, we turned to a source of data that I'm sure is familiar at some level to many of you, and that's the weekly bills of mortality from the City of London, England. And so we're going back to times when London had a beautiful covered bridge where people lived, not the ugly modern London Bridge that exists now. So here's an example of a bill of mortality, and I'll just highlight a few examples. So it tells us on the left panel the number of people who were believed to have died from various causes in this particular week. So for example, somebody was frightened to death. There were 3 people who died of grief. But most impressively, there were more than 5,000 people in a city with a population of about 500,000, in that 1 week, more than 5,000 people were recorded to have died from plague. This was a bad week, though not the worst week, I should say, this particular week. So we have the bills of mortality, but they go back only to 1563. The earliest surviving bills are from 1563. That's very helpful for a number of plague epidemics in the 16th and 17th centuries, but we're interested in going back to 1348. There are death registers that go back to 1538. That's the year that deaths first started being registered in London, but that's still not going back far enough. And so we turn to documents that historians have studied for many years that can give us clues, and that is last wills and testaments. They're obviously restricted to wealthier individuals who had something to leave in a will, but these documents survive and they go back to the 13th century. So, I'm cutting a long story short. I once spent long periods over a couple of weeks typing in the dates of more than 1,200 wills myself to get at, to see if I could see patterns. And here's what happened. Here's the data and I'll plot this in various ways, but so from the 14th century, this is on a log scale, the number of wills that were written over the course of the 14th century in London. And I've highlighted in yellow the years when there were known plague epidemics. And you can see that there are peaks, and there are high peaks, this is a log scale, at each of those times. So the wills did peak during those years. In the later years, we have wills again. And so this is weekly wills over from the 14th to 17th centuries. But then we also have the parish register, death dated by parish, and then we have the bills of mortality, which are more selective, but those are the best data because they're actually give counts of deaths from plague to the extent that we can believe them. So what do these look like in a little bit more detail? So here are a couple of the periods of the epidemics. This is just counts of wills that were written in London each week in 1348 and 1361, and it's pretty clear something happened there. We can see a pattern of an epidemic of wills. Let's think about what we can make of that. Then in a later period, here's a couple of later epidemics for which we have all three sources of data, and you can see that, well, they sort of roughly coincide. They're clearly all associated with the plague epidemic. But we want to study the wills because we'd love to be able to compare the pattern of epidemics in the 14th century with the pattern in the 17th century and see what we can learn, maybe if we can put some mechanistic insight and use some modeling to try and make sense of it. How can we do that? So we asked the question, is it okay to compare this epidemic pattern in wills in the 14th century with the more reliable 17th century data for which we have the three sources of data? So here is the Great Plague of London in 1665. This is the actual number of plague deaths that were published in the bills of mortality. And here, scaled, the numbers are actually different, is the number of wills each week. And you can see that they actually, given that the wills are obviously noisier, they're smaller numbers, but they match up reasonably well. And what's really striking is that if you look at the period of growth, the slope is about the same. So really, the wills are capturing the rate of growth of the epidemic. Bingo. That means that we should be able to safely compare the initial growth rates of the epidemics in the 17th century with the growth rates in the wills in the 14th century. So we did that. And you may say, okay, well, so how do we do that? I meant to say too, a key thing too, a nice thing about this is a feature of the epidemic curve, that growth rate. So we don't have to know when we estimate it how things were transmitted. We don't know if it was pneumonic or bubonic plague, and these things could make all of our analyses more complicated. But we can estimate the growth rate without knowing that and then compare across epidemics. So that's great. We have a feature that we can estimate of these epidemic curves and then compare. Okay, so we don't know what the mode of transmission was, but we can estimate the growth rates. And how do we do that? Well, if we put, this is the Great Plague of London again on a log scale. And so on a log scale, if we want to estimate the initial exponential growth rate, we just fit a straight line, and the slope of that line is the exponential growth rate. Straightforward, right? I mean, any high school student can do this, right? Well, the thing is that I might think that that looked like the period of where there's linear growth on this log scale, but you might think that that's the period where there was linear growth on this log scale. And that's a big difference in the exponential growth rate. So we've got to do better. We've got to have a technique for actually estimating the true exponential growth rate more reliably than doing this by eye in this way. So years ago, we spent a long time developing methodology in order to reliably estimate exponential growth rates. And the key thing is, and I won't go through details, is that rather than a simple exponential curve, we fit a saturating curve, which has exactly the same initial exponential growth rate as the pure exponential curve that I draw, but turns over as epidemics always do. And it turns out that if you use this type of fitting so that you allow the curve to change the way that epidemics do, you can estimate that initial epidemic growth rate much more reliably. And we know it's more reliable because we've tested the methodology on simulations where we know what the right answer is. And we've tested it very extensively. Okay, so we have a good way of estimating those exponential growth rates. Amazingly, what we discovered was that the growth rates in the 17th century were 4 times faster than in the 14th century. That is stunning. Another way of saying that is that the doubling time, the time it took for the number of wills being written to double, or the number of deaths occurring in a week to double, was about 45 days in 1348, but only about 11 days in 1665. That's an enormous difference in the character of those epidemics. Wow. Okay. So then, of course, you can say, okay, well, what caused this kind of acceleration of the plague dynamics? Well, we don't know, but there are various possibilities that we can investigate. It could be that the pathogen became had more infectious, or had increased infectiousness because of, or had a longer infectious period, and so was able to, each individual was able to infect more. Changes in the population density, social structure, contact patterns, all of these things happened over the centuries in London. There were changes in weather. I mean, you may know that the Little Ice Age occurred in the Middle Ages, and so over this hundreds of years of periods, that change in weather may have impacted. And then, of course, it may be a difference between bubonic and pneumonic plague. We don't know that. What we're measuring is growth rates. Okay, we don't know the answer to that. However, we can do some modeling that gives us a bit of insight. So we can ask the question, you know, for modern bubonic and pneumonic plague, we actually know a lot of details. So for example, we know the latent and infectious periods of pneumonic plague for pneumonic plague that still occurs in the modern world. Well, if we assume that the parameters for those quantities were the same in historical epidemics, then we can ask the question, is it plausible that that what we were seeing were epidemics of pneumonic plague? Okay, so for example, could the epidemics that I showed you have been pneumonic plague in the 14th century? Well, based on this assumption, if we then use a mathematical model to calculate what the expected number of individuals who would have been infected throughout the whole epidemic were, we get about 15% of the population. Whereas that is nothing like the 30 to 50% that people estimate having actually died during the epidemic. So it's not consistent. And these are rough numbers. On the other hand, they're so far apart that I think it's reasonable for us to conclude that the early plagues were at least probably not primarily pneumonic plague. Of course, there might have been some pneumonic plague, but it's not plausible that they were primarily epidemics of pneumonic plague. And, you know, at some level, that's kind of a weak inference. they're probably not. They probably weren't entirely pneumonic plague. On the other hand, bear in mind that I've come to this inference by counting the number of wills that were left in the 14th century, and then doing a bit of mathematical modeling. So I think it is remarkable that we can take data like numbers of wills and turn it into an inference about infectious disease dynamics. Okay, so that's all about the temporal patterns of plagues. We also have data on the spatial pattern, and we can ask questions about how plague spread, for example, in London. Did it enter the city very quickly all at once, or did it spread slowly? What happened? What was the pattern? And that's not only interesting for its own sake, because we can use the spatial dynamics potentially to actually estimate, because we have a lot more data then, we can constrain things like the latent and infectious periods back then. So that's a possible way for us to make use of these data as well. We can explore the plausibility of the transmission mode and so on. Well, the spatial data are in the right panel of that bill of mortality that I showed you. So here's a blow-up of that, and you can see that for each of the 130 parishes of London, we have the total number of people buried and the number of people buried because they're thought to have died of plague that week. And this is a reprint that's been typeset. In fact, most of the data that we digitized looks like this, so it's actually like templates with handwritten numbers on them. Fortunately, I don't know how clearly you can see here, but the numbers are almost always extremely clearly written. So digitizing these was in fact plausible to get reliable data. So we did that, and then I can show you what the pattern of spread of plague in London was in 1665. So what I'm going to quickly do is color the 130 parishes of London in the order in which they were infected. That is the order in which a first death from plague was reported in a bill of mortality. So it started in a parish outside the walls of London. The yellow here is the wall of London. It was a walled city. And this is the Thames River. And the black bar here is London Bridge, which was the only bridge across the river at the time. Okay, so I'm then going to move forward. It seems to be spreading to nearby parishes, took a bit of a jump. And at this point, in the following week, it has gone through the walls and in two places. So there's a major gate of the city over here, I will mention, and it seems to have crossed the river across the bridge. And if we keep going forward, then I think you can probably see that over time, and we're talking about months of time, these clicks are weeks. It took over months, it finally encroached on the very center of the city. So there was spatial spread that's very evident. Okay, now I'll mention that I made this animation many years ago, and there was a Nature of Things episode that the CBC made, which is mostly about my colleague Hendrik Poinar, the Indiana Jones. But they interviewed me, and they had me explain what I just showed to you to Hendrik. We did it for hours, over and over again, and I thought there were going to be these great animations of mine on the nature of things, but they decided in the end instead that my animations weren't adequate for television. And so they produced this instead, so I'll show you that. So this is the CBC's version, so they have David Suzuki talking over this and saying, it was so scary, and the plague came out on the side of the city, and then at some point you can see that the plague burst through a gate of the city of London, and then in a flash it spread through the rest of the city, and he's going on and saying, it's like, it's so scary. And when I saw this, I thought, really? But you filmed me for hours saying how remarkable it was that it took months for this pathogen to spread over this tiny area of a few square miles. Anyway, their animation is certainly better, but it's not as accurate. Okay, so that is the spread of the Great Plague of London. And I'll show you one more quick animation which shows, so what you were just seeing in both those animations, you're seeing the initial spread. But of course, we have the data throughout the epidemic. And this is an animation showing the full epidemic. And what you'll see is that, I don't know if you can see it, but in the top right corner is the date, so we're in March of 1665 now. And you'll see eventually soon now, there's a bar that popped up, and we're gonna see, and at this point, all that initial spread is completed and we already got to the center, but you're now gonna see the per capita deaths all over the city during the Great Plague of London, which is a stunning pattern of this plague epidemic. So initially there was all this spatial spread, but then it's just raging throughout the city. And very interestingly, we're now in November of 1665, where it's died down and it's sort of finishing, but it smolders for another year before giving up. It just continues to smolder and smolder. So these raise all sorts of interesting modeling questions so for us to understand why it looked the way that it did. But that's for another talk. I want to give another example now of epidemics that we have been able to study from the London Bills of Mortality. There were 4 cholera epidemics in the 19th century. And here are the weekly mortality from cholera in London throughout the 19th century. And you can see, I've now colored in red, the 4 pandemic years. And these were giant epidemics compared to the typical annual epidemics that you may be able to see were occurring. But very interestingly, when we studied these epidemics, we found that before, well, 3 out of the 4 epidemics, you may be able to see in yellow, before 3 of the 4 major epidemics, there was what we called a herald wave. There was an out-of-season, larger epidemic than normal. So here's the example of 1832. So we had this huge epidemic in 1832, which normally occurred in the 3rd quarter of the year, these cholera epidemics. But there was an out-of-season epidemic here that occurred beforehand. Similarly, in 1849, there was a smaller but still out-of-season epidemic that occurred in the previous year. Also in 1854. In 1866, there was no out-of-season epidemic that preceded the pandemic. Okay, what inferences might we be able to draw from that? Well, there were these 4 cholera epidemics. 3 out of 4 had an out-of-season herald wave. We suggested that might represent a new strain of cholera actually invading that came into the population out of season, but didn't cause a major epidemic if it came in out of seasons because conditions weren't ideal for the spread of cholera. So instead, it caused a smaller epidemic, which then blew up into a giant epidemic once the normal season suitable for cholera happened. So that's a possibility. And we wanted to investigate whether that's really plausible from the point of view of mechanistic mathematical modeling. And so we modeled it, and this is what we found. So here are the actual data for one of these epidemics in 1849. And here is our mechanistic mathematical model, which has so you may be familiar with the SIR model, susceptible, infected, and recovered. This has a water compartment as well, which we affectionately call the sewer model. What we found was, indeed, if you introduced a new strain at around the time where that small epidemic occurred, you get a pattern that's very similar to what was observed. And the model includes a seasonal variation in transmission through the water, and also we keep track of pathogen concentration in the water. Again, the details of this are very interesting, and I'll be happy to talk to people who are interested afterwards. Before 2019, the pandemic that was most salient for most of us was the 1918 influenza pandemic. And indeed, I had given many talks where I showed this graph. So right now it's 106 years ago. This is Daily mortality, another data set that I got digitized from, this is from individual death records during the pandemic. So this is Ontario, deaths in Ontario in 1918, the entire year of 1918 up to May of 1919. That's all deaths. And then we also have pneumonia and influenza only. And you can see that that big peak is, of course, caused by influenza. In other, there are in fact 3 waves here, but they're not as evident as in, for example, the UK. So this is London again, which we've studied in great detail. And you can see here there were 3 epidemics of influenza in London in 1918 and then early 1919. And the fact that there were these 3 waves, I mean, that was so important in the COVID pandemic for people framing, oh, how many waves will there be? There's always this discussion of how many waves were there? Do we know there will be 3 waves like there were in 1918? Anyway, we wanted to try to understand why there were 3 waves in 1918 when it was an influenza pandemic. And so to do that, we built a mechanistic model, so for those familiar, built on the idealized SIR model, but including more. So we, in addition to just simple transmission, we had a number of factors that we included in this model. So one was that we took account of behavioral response, that people would reduce their contact rate if they knew that tons of people were dying, which is entirely expected. The other thing is that we knew that transmission would be lower when schools were closed. And then the third thing was that we know that influenza transmit better in winter temperatures and humidity, and so we included weather in the model. And when we did that, we got this result. The red is the actual data, and then what you're seeing in the temporal box plot is a box plot of 1,000 simulations of a serious mechanistic model. And you can see that it fits extremely well. So when we include all these factors, we do seem to be able to explain these data. So then, but what does it mean to explain? So we asked, well, what if we didn't have each of these factors? Would we be able to generate these 3 waves? So when we leave out the behavioral response, we can't. So this is the best that we can do by including only school closures and weather. And it's terrible. We don't get 3 waves. We get, the best we can get is 2 waves, and it doesn't look anything like the real data. On the other hand, if we leave out school closures or we leave out weather, we're able to generate 3 waves, not as well as when we include them. There are detectable significant effects of these processes. But what we learn from this is that behavioral response seems to have been extremely important in generating that pattern of 3 waves. And I think after the COVID pandemic, you'll find that very plausible. If you look at the 7 or 8 waves of COVID that we have, it was clear that it wasn't, of course, there was also the variants, and it's complicated, but behavioral response certainly had something to do with it. Okay, I'm almost through my historical examples, and I'll just say very briefly, I mean, I don't know if there was a smallpox pandemic. It's sort of when smallpox was introduced a very, very long time ago, but whether it really spread around the world very quickly, that the world of the time was very different. But it would have been an extraordinary event when that pathogen first entered human populations. And we have studied it in London, and I had a PhD student, Olga Krylova, who looked very, very carefully at these 3 centuries of weekly smallpox data in London. It's an incredibly interesting pattern. And just at a glance, you can see that the interepidemic period changed over time. The character of the epidemics changes enormously over time. And she looked for explanations of this. So key things are that there were changes in the birth rate over time, which influences the influx of new susceptibles. She dug into thousands of historical documents and with times of wars and policy changes in relation to smallpox, in particular looking at the uptake of variolation before vaccination and then the vaccine from the late 18th century onwards. All of these things are in fact correlated with changes in the patterns of smallpox epidemics. What we find is that changes in birth rate, contact rate, variolation, and vaccination are associated with the patterns of disease prevalence. And another talk would be to tell you why that is. And the way that we do that is by mechanistically modeling all these processes and asking, well, what should happen if birth rates change? What should happen if what should happen if vaccination levels rise in this way? And we use the mathematical models to then predict whether there should be annual epidemics, for example, or every second or third year only, or very irregular epidemics. These are things that only a mechanistic mathematical model can predict, and we can then test that against the data that I just showed you. Okay, so I've shown you examples of a variety of pandemics. So I talked about plague and smallpox, and I didn't talk to you about some of my favorite diseases, measles, rubella, whooping cough, which I could go about at length, or I said a little bit about the 19 influenza. I didn't talk about the 2003 SARS epidemic, which wasn't quite a pandemic, almost, fortunately not, or COVID, or more recently Mpox. I don't know whether I could spend another 5 minutes talking about COVID and what we did during COVID. Should I? Yep. Yep. Okay. So, all right. So, here is weekly, I showed you weekly mortality in London from various diseases. This is weekly COVID worldwide. The scale is rather different, 45 million, this is cases in a given week. These are just the reported cases officially from our world and data. You can argue for a long time about imperfections, but these are the reported data. And you can see the sequence of waves. And I've now plotted it on a log scale. The red is still, and I didn't go, so this graph goes all the way to the present. This doesn't quite go to the present, but I'm showing it on a log scale. And I'm also showing you on this log scale, there would be no point showing it on the linear scale. This is the 2003 SARS epidemic on the same scale. Nothing. There were at most, a few hundred cases in the day, not the millions of cases that we see here. So what I've also shown, though, is I don't know if you can see it clearly, but there are little green bars along each of these epidemics. And all the way through the pandemic, one of the things that we were doing was estimating the initial growth rate using that technique that I mentioned in relation to plague. And this allowed us to have a clear image of the doubling time, which I've written on the top here for each of these waves. And we could see how it was changing as a function of variant and various other things over time. And that was very useful for very short-term projections. We also did this in Ontario, and of course all these graphs were shown to the modeling table and some of them to the science table. And I just want to give an example of what, and I've shown you all these historical data. I haven't shown you all the details of the modeling that we've actually done, but the experience modeling all those historical epidemics is what put me and colleagues in positions so that we could actually do something useful during the pandemic and provide some insights and projections during the COVID pandemic that I like to think helped in managing things in Ontario, in Canada, and elsewhere. And the thing is that unlike the data that we've scrounged for these old epidemics, which are amazing and allow us to make some exciting inferences, they're much more detailed and richer. We have daily counts of all sorts of things, and tests, and there are close to 1 billion people reported having, I think it's 700 million or something, having been reported officially as having had a positive SARS coronavirus 2 test. So there's vast amounts of data, and we have data on all sorts of aspects of that influence disease transmission. But we have a much harder problem if we're trying to forecast the future than if we're trying to understand what happened in the past. And what we did, though, was similar to what we've done for these these older epidemics. So we start from a simple mechanistic mathematical model and expand it to include the ability to take advantage of the various types of data that we have. And when we did that, we could then make inferences about what we would expect under various scenarios going forward. And that's what turned out to be valuable in discussions that might potentially impact decisions. And of course, we never capture every process. It's always imperfect. And so we work very hard to try and put confidence intervals around everything that we produce. I'm going to show you what is, I acknowledge, the very best example throughout the pandemic of how well we did. And that was during the alpha wave invasion. And these are graphs that, actually these graphs actually, one of these graphs made it into the Globe and Mail, so this was, people did pay attention to this. So you may or may not remember, in very early 2021, we were in a lockdown and cases were going down in Ontario. This is Ontario, and the observed cases are the black dots. And we needed to make a forecast on this date that I've isolated here, which is in late February. And at that time, there was no indication to anybody who was looking just at the data of cases that there was going to be anything different than a continuing decline. However, we knew, because the alpha variant, not yet called the alpha variant, but had been taking off already for several weeks in the UK, we had very good data on the transmissibility of alpha in relation to the ancestral strain. And we were able to include that in a model and then project what would happen over the course of the alpha invasion. And we produced this pair of projections. One was, this is what we were asked, because the government wanted to know what happens if we open as planned on this date here. So there was a planned reopening. Well, if you ignore the fact that alpha was invading, then we projected this slight increase. Didn't look too bad. But if you knew that alpha was invading, as we did, then instead we projected this incredibly sharp increase if they opened as planned. And, well, I mean, you may remember what happened. Of course, we were ridiculed for this rocket ship projection. And then, okay, what happened? So reopening actually happened, and then they did it on the date that it was planned. And then in the open dots, I'm showing you what actually happened. So remarkably, it actually followed this projected plan as we predicted. And then after that, there was this big response. So like the government knew this in advance and they didn't do anything. And I don't actually blame people, because it's so hard to make these decisions. And I understand looking at the graph and saying, oh, the cases are going down. I mean, how can I tell people they have to say? But the ironic thing is that I think we actually got a lot of credibility after this, I hope deserved, after this, these projections. But had the government not opened up, then it would have been the effect that I think David mentioned this morning, which is that, if they followed what we said they ought to do, then there wouldn't have been this big epidemic, and then there wouldn't have been any evidence that we could have got it right. And it's a no-win situation. Okay, so of course we kept doing forecasts, and a bit later we had better data, and so we made another forecast here, and then the projections were even closer to what actually happened. So that went extremely well. Later, things were more difficult because the data became a lot more complicated. Okay, so I said a lot about, I'll finish up now, yeah, about historical data. I just want to mention that one of the things that came out of the pandemic is that I've been leading, together with my colleague Karen Collane and Simon Fraser, this national group of modelers. And one of the key priorities was to digitize Canada's history of infectious disease data, which we have finished and will be released soon. And I could talk at length about this because I got so excited about it, but we've turned a bunch of mixture of handwritten and typewritten spreadsheets that I've gathered over the last 20 years. They've all been digitized now and are now in beautiful harmonized form, which soon will be downloadable by anybody who wants to study the history of any infectious disease for which there has been surveillance over the last 100+ years. So I'm very excited about that, and I hope that you are too. And I will just say thank you very much to the many people involved in the research that I talked about, and I look forward to more discussion.
On. Hello. There we go. All right. So I think we have a present for David. We'll do that at the end. All right. And we have so thank you, because that was fantastic. So we have a panel who's going to share their thoughts on this presentation. Allison Simmons, do you want to just come up to this? So Allison's a PhD candidate at the Dowlana School of Public Health. Jude Kong, there's Jude. So Jude is a professor at the Dowlana School of Public Health who works on both modeling and artificial intelligence. And Ashley Chute. Ashley Chute's an infectious disease epidemiologist at Public Health Agency of Canada. So what I'll do you want to sit down? You've been standing for a while. I'm happy to. Why don't you have a seat and rest for a moment? But I'll ask each of the panelists to give maybe a 5-minute reaction to what David had to say. Why don't we go in geographic order, starting with Ashley? All right, over to you.
Okay, thank you. I guess I just will start by saying that I liked your talk a lot. I think the thing that maybe not everybody in the audience will appreciate is how valuable that digitization of the historical data will be. I think as modelers, we talk a lot about the importance of having data, and the COVID-19 pandemic was really, really unique in the sense that we did have access to data in a way that was unparalleled. But the reality is that for most infectious or communicable diseases that we're interested in modeling, we don't have that sort of data. And one of the things that's really important is understanding baseline. And so having access to that historical data and understanding what disease transmission looks like is huge. So very excited about that. And I think it will be a huge resource for us as a community. One of the things that I was reflecting on was, the question of, lessons learned from modeling past pandemics, is that a lot of the things that you were pulling out are things that we saw also during COVID, particularly the importance of behavior. And as I reflect on the talk we saw this morning about cities and trying to understand how cities or how downtown is recovering and the use of cell phones, I think that's one piece, or cell phone data. I think that's one piece of information that, again, was unique for us to have access to, or for some people to have access to during this pandemic. And I guess, I don't know if I'm supposed to ask questions or just reflect, but I would love to have your reflections.
It's your 5 minutes.
Okay, but I'd also like to hear the reflections of other people on the panel in terms of, do you think coming through the COVID pandemic that we've gotten any better at trying to understand behavior? And if if the mobile phone data is an example of something that would help us get there, and just sort of curious, because I think that's always going to be the challenge, is that, you know, you can build the best model in the world with all of the data that you have, but if you don't understand that human factor and how human behavior will impact the models, that's always going to be a challenge. So I guess just putting that out there.
Thank you. David, do you want to respond?
Sure. Thanks, Ashley. I mean, I guess I haven't done it myself, but it seems to me that all the cell phone data and other data for monitoring individuals that we have now ought to allow us to parameterize models of behavioral reaction. In principle, it should. You know, when we did that work on the 1918 flu, we did no such thing. We had a very phenomenological model with a few parameters, but it would be so much better to have rich data like that from which one could build a better mechanistic model of behavioral response. Honestly, whether it would have a big impact on the inferences that we made at the population level, I don't know, but it would be valuable to do that.
Thank you. Jude, would you like to share your thoughts?
Yeah, thank you so much, David. My name is Jude, and as I was listening to David, a lot of things were coming in my head. And when he talked about the later on when the Dublin rate became very faster between the Index 48, I was like, but what if I was a slave at that time and I was not being considered as a human being? Or what I was something else and I was not being considered? And when I actually talk about human behavior, bringing different voices to know what is happening within the communities in London or within communities in Canada, that became very vital because those are the living documents that you will know. You may have the data. The Dublin rate may have been high in 1638, also David, but unless you had people from all those communities sitting on the table and informing you, unless you knew how people act, human behavior that I talk about, when there's a pandemic in different communities, your model will not be able to capture it. Yes, modelers will always try to, but what about the data that's used to fit in the model, train the model? That data will not capture it. So there was a lot of importance on, when we talk about the data, going backward and looking at all of those. Even if you look at the will, how many people could write a will at that time? Meaning that you need to bring in people from different communities with different voices to sit on the table, to give in their own feedback on what is happening in their own communities if you are looking at that behavior. If you want to find out nowadays, he said, well, when that was happening, or when John Snow was looking at cholera, was your community taken into account? Maybe you didn't have sewage. Maybe you're just using a big toilet, like most people. But for that to happen, you need to have those voices. For you to understand human behavioral dynamics, you need to have all the voices on the table to build the mechanistic model that we build. And that's very vital as we move forward to prepare for future pandemics and epidemics, to have different voices on the table, to ensure that people are able to describe what is happening in their communities, to ensure that the data is representative, because otherwise we end up having data that represent only a proportion of the population in our communities. So the communities are living documents that needs to be taken into account, and we need to learn from the communities rather than sitting on our tables, building models and take it to the community and saying, this is your problem and this is your solution. And that's the way forward. And thank you so much for sharing this.
Thank you. Allison, Allison is kind of in this interesting position of having turned into a full-fledged infectious disease modeler and epidemiologist during a global infectious disease catastrophe. So I'm curious what your thoughts are on
Sure,
on
yeah.
that topic.
So, can you all hear me? Oh, can you hear me now? Okay, perfect. Thank you so much. I just wanted to reflect back on two other, I guess, epidemics, pandemics that I experienced when I was, or that I studied as an undergrad that actually made me want to study infectious disease epidemiology. And Dr. Ernst's talk really brought me back to those moments. The first was when there was the Ebola epidemic in West Africa, and at the time, I had sort of the luck and the privilege of taking a virology class, a mathematical models and biology class, and an epidemiology class simultaneously. So that really brought that really created my interest in modeling, and actually looking back at the time, I actually read a paper by Dr. Toot and Dr. Fissman in that class in 2014. And then the other thing I'd like to briefly discuss is, while I was taking those courses, and this connects to behavior change, a lot of my professors were on campus during the H1N1 epidemic. And it was a closed population, which as a modeler is very interesting. And what they actually saw was a big peak in influenza cases and then a drop. And then what they did is they had a vaccination clinic on campus. And after that clinic, they saw a huge rise in cases again. And what they realized is that they can completely change the contact patterns and the behaviors on campus of the students and created this extra peak. And it really brought me back to the importance of behavior change and how that can really influence the spread of disease. I can talk about the pandemic a little bit, I suppose.
Sure.
Yeah, and being a student during the pandemic was a great experience. Finally, my family members and friends understood what I had been studying, and it's really an honor to be on this panel with some amazing leaders that really led the COVID-19 response in Canada.
Thank you so much. Does anyone, and do any of the four of you have additional comments you'd like to make before I open this up? Well, why don't we, you know what, I'm going to just, because I'm holding a microphone, I'm just going to make one quick comment, and it's not on your bio, but you're an astrophysicist originally. Sort of, yeah, okay. Dabbled, or yeah, you're an astrophysicist originally. So just in terms of the Isaac Newton parallel, we have a late colleague from British Columbia named Babak Purbalal, who was another physicist who turned into an infectious disease modeler. And Babak had this really insightful series of comments that he would throw into his talk. One was that we use models to go from data to knowledge and understanding, because when we understand things, we can predict and control. And what he would always do is he would tie this back to physics. For any of you who watched the eclipse last week, you knew exactly where the shadows were going to be at what time. And what Babak would have told us is that is an example of going from data to model to data to model to data to model over a period of a couple of hundred years, and your predictions become incredibly precise. We're in early days with infectious disease modeling, and then I think each of the three of you, and David, of course, in his talk, had mentioned the X factor that makes this different from physics and astronomy, which is human behavior and the feedbacks that go along with human behavior. So I think that, that, and we have all kinds of ways that folks have tried to come up with clever ways to deal with human behaviors. It's cell phone data, movement data, office occupancy data, what have you. But that really, to me, remains the real X factor in terms of telling people what's going to come next. Because you even have this problem that if you tell people what's coming, they change their behavior in response to what you say. So I'm not sure if the microphones are, we have a question over here and another question. This gentleman, Sabina Vormiller, I think is right here for the first question.
Hi, thank you so much for that fantastic talk. I guess my question is probably slightly different in terms of, we understand the importance of modeling, we understand the importance of data, but because this is a newish field, my question to you all on the panel is, how do we actually teach people the importance of it? So going back to things like, you prepare a model, but there is a prevention paradox. You see how it kind of, what you're trying to do actually works, but then people come back and say, well, your model was wrong, right? Or we're talking about things like, basic things like base rate fallacy. And in fact, people in the government sometimes don't understand these concepts. So I think, as a science communicator, we can have the best data, we can have the best knowledge, but how do we actually convince people about this, and how do we actually change behavior based on that? And I think that is like something that I feel is a huge question mark. And so wondering if any of you have given some thought on this and what we can do to combat it.
Thanks. I'm sorry, there was a bit of an echo. I found it difficult to track exactly everything you said. But my own experience with conveying to people the importance of mathematical modeling of infectious disease has, I guess, changed a bit over the years. I would say early on, I tended to motivate things by saying, because this was really my own interest, I've always had this fascination with history and understanding epidemics of the past, and I would make comments like, we want to understand the universe that we live in. I would say this when I was studying astrophysics as well. And spread of infectious disease is a fascinating part of population structure and dynamics. And the more we can understand about the past, the more we understand the present. And I think that's enough for me. Like, I don't need there to be an application that says, yeah, we're going to save a million lives if we make this mathematical model. I wish that was as simple as that. But over time, I've been drawn into, especially during the pandemic, work that actually does impact people's day-to-day lives. And then it's really easy, I find, to convince people. I mean, if I show things like that graph of predicting the alpha wave, people tend to be extremely convinced that this is a valuable exercise of mathematical modeling. Not everybody, there's always detractors, but you can give examples of where it works, and you can see how it could help people. For myself, I still, after all this, find the intrinsic understanding of spread of infectious disease to be fascinating and a worthwhile scientific endeavor, and I will always try to convince people that that's worth it for its own sake. But in terms, if you're really looking for, we must fund things that are applied, then I think it's pretty easy to argue now that infectious disease modeling is valuable for public health.
I just wanted to quickly add, I think one of the things that, well, I guess two things. One is I think modeling is a lot easier to communicate when it shows people what they want to see. I think the challenge is when it goes against either your intuition or what sort of is your leaning in terms of what you think we should be doing. And I think one of the other criticisms that I often get when communicating models is, there's so much uncertainty. We've just talked about, all of the data inputs that go into it, and we don't know this and we don't know that, and we don't understand human behavior. And I think the counter argument to that is that, it's a tool. We have all of these various sources of information, and this is a way for us to synthesize that information and help us understand the world better. It's not going to tell you precisely, the number or exactly what to do, but it can help you get a better understanding of, if you're thinking of taking this particular course of action, or if you're considering this intervention, this is what you should expect to see, and you can use that information as you wish. But I think one of the things that's really important about modeling is that as much as it is presented as a quantitative field, it's really those qualitative insights that are really important. And I think that communication piece is really important. And I think David is a really good example of how you do that. And so I think it's a challenge because it is, it's math, and some people just see that and don't want to hear it. But the reality is that it's really a tool for helping us to sort of make sense of the universe, as David said.
I wanted to just add to what Ashley said in terms of being a tool, in that you don't teach the communities, you don't go to community and know better than them, you learn from them. And you're equally a tool to be used by them. So if you're using mathematics to illustrate something that the communities have identified as an issue, you are one of the pieces. So you don't sit there and want to teach the communities, you don't want to teach the public, but rather you're learning from them, working with them, and then building those models and illustrating. Again, what you are doing, you don't know all. You're just an additional piece. When people come and describe what is happening to somebody like David. Then you build a mechanistic model that capture what they are saying and say, oh, this is how this can be built using calculus or using some of the things that you have done, and this is how I can analyze this. So you don't teach them, but you build with them, co-create with them, and then use that to inform policies. That's what I wanted to add.
Yeah, a question that's sort of wrapped in a comment that's buried in the question that the previous questioner just asked, and also Dr. Jha's presentation this morning. Your graphics and the difference of opinion you had with the CBC about how to present information seems to me to be at the crux of what we need to do as public health professionals in terms of getting the general public, the general public to understand what the numbers are all about. I think people do better with pictures than they do with just tables and numbers. And I think one of the challenges in communication in public health is making graphic representations that make sense to people, that people can understand, because this is a visual society these days. And you know, a 60-second TikTok video or YouTube video probably garners more attention and hopefully more understanding than a 10,000-word article in the New York Times or the Globe and Mail. So what do you think is the best thing or the best things that we can do to improve the use of things like graphics and visuals in getting the public health message across?
Thanks. I mean, I guess, you know, what you're promoting is exactly what I always promote to my students. You know, when you're giving, whether it's giving a formal talk or you're talking to the press or you're talking to public health individuals or somebody in an elevator, you need to have a way of explaining things clearly and simply without getting into all the work you really did. And that's a huge challenge. I agree that good graphics are incredibly valuable. There's also a danger that I was hinting at with the CBC thing, is that sometimes you get carried away with the graphics and it can be distorted and it can tell the wrong message. In that case, I don't think anything bad happened. But sometimes, you know, you can, you know, there's this classic book called How to Lie with Statistics, and you can, if you present things visually in a devious way, then it can tell the wrong story as well. So we just need to be sensitive to that and understand that most people find, as you say, especially animations, really engaging. And you know, people tend to be much more excited when I show these animations than when I write down some differential equations and I enthuse about how I solved them, you know, unless they're, you know, mathematicians. But so I agree with you, basically. We need to be sensitive to those issues.
And as much as the CBC graphic was held up as sort of a cautionary tale, I would say that early in the pandemic, we had some really great collaborations with news outlets, like the New York Times and Washington Post, where we sort of worked together to help them try to do those sorts of infographics. And, you know, we can advise, but ultimately, like, I hope I'm speaking for everyone on the panel, we're not graphic designers. And so that sort of collaboration, I think, is really important as well.
Talking about Ashley's collaboration, it's very important that when you go on to co-create these issues that the communities know better with the communities, learning from them, you build capacity in the community. So meaning that they have data managers within the community, which means that if you have learned how to illustrate something, you spend time with them to show them what they have. Oh, this is how you can illustrate this. And then spend time over the time. Once you do that, those community managers will be able to explain to others, and that's how you co-create, learn from communities, build capacity in communities by doing that.
I'm just going to build off that real quick very quickly. During the pandemic, I was involved in a few data dashboards, of which many of this panel were also involved. And it kind of connects to Jude's last comment. And so we tried to build accessible visualizations for data and translate more quantitative public health data into like beautiful visualizations. And the most helpful thing for me as someone who's creating a dashboard was to get feedback from the community. So I had folks come up to me and say, hey, it'd be really interesting if you added this. And I was like, that's great. So I think it all connects where building beautiful visualization so people can understand the data, but also integrating community feedback as you go makes it most accessible for all.
With that, we'll wrap up our session. And thank you very much to David Earn for a marvelous lecture, and thank you to our panel for their very thoughtful comments.